I want you to imagine something with me for a moment. Imagine walking through Times Square. It's New Year's morning, let's say, 2026. The neon lights are still humming, but the ground is just a graveyard of frozen confetti and, those sodden masks. The city should be waking up to a fresh start, but as you head uptown toward the big medical centers, the silence is, well, it's jarring. There are no sirens. Instead, there's this rhythmic, almost hypnotic thud of picket signs hitting the pavement, and this low murmur of a crowd that is definitely not celebrating. I stood outside a major hospital that morning, and I watched an older man, look like a retired surgeon, you can tell by his coat, just staring at the line of protesters. He wasn't shouting or anything, he was just watching. And he sees the socialist mayor pull up in a black SUV, not to negotiate, no, but to hand out coffee with the union leaders. And this surgeon, he turns to me, and he says something that it just felt like a splash of cold water. He said, "We spent a century building the greatest engine of healing in human history just to watch it become a political bargaining chip." He pointed to the picket line, where the chants weren't about nurse-to-patient ratios anymore. No, they were about dismantling the capitalist hierarchy. And there was this strange, almost giddy energy among the organizers, a sense that they weren't just winning a contract, but they were finally breaking the system. But then a young woman ran up to the entrance, clutching a child who was so clearly in respiratory distress. The crowd didn't part. The chanting didn't stop. The virtue of the movement just hit this brick wall of biological reality. And for a second, the festive mood just vanished. It was replaced by this haunting, stagnant silence. That moment, that instantaneous shift from ideological triumph to the realization that, the elevators had stopped moving and the beds were empty. It felt like a premonition. We used to look at the European disease, the endless strikes, the crumbling NHS, the bureaucratic decay as some distant cautionary tale. But standing there in the biting New York wind, watching the city's literal lifeline being severed in the name of progress, I realized we weren't just watching a strike. We were witnessing the autopsy of the American idea. How did we get to a point where fairness means nobody gets care at all?
That scenario, and the way you describe it, it's fictionalized, but it cuts right to the heart of what's becoming a civilizational warning. When the delivery of something as essential as medical care gets tangled up with political and social movements, when these services are weaponized or undermined by ideological shifts, what you're seeing is the erosion of the social contract. What you described is exactly what some would call the British disease, right? The endless resource strain, the strikes, but manifesting in American urban healthcare, where certain municipal policies seem to prioritize political goals over economic solvency.
Okay, so let's unpack this whole picture. That's our mission for this deep dive. We want to connect those two worlds, the internal ideological pressure cooker that's shaping our future doctors, and the external practical reality of what happens when healthcare systems start to fail. We've got sources detailing the massive centralized influence of the Association of American Medical Colleges, the AAMC, and how it's steering future physicians away from a meritocratic focus and, toward activist ideology.
And that internal decay, that shift in priorities, it's happening at the exact same time that the U.S. system is starting to mirror the resource struggles you see in centralized bureaucratic models.
The NHS-ification of our medical centers, as some are calling it. We also have a really unique qualitative comparison from patients who have lived in and experienced both systems, the highly privatized U.S. system and the universal UK National Health Service. So our goal here is to connect the decay of the American merit system to the bureaucratic issues we see in European welfare models and really understand what that means for you, the patient, waiting for care.
To really get a handle on the transformation of American medicine, we have to start with the central mechanism driving this change in medical education, and that is the Association of American Medical Colleges, the AAMC. This organization, it's not just some advisory body, it's a massive bureaucracy with nearly 150 years of influence, and it controls almost every single step of a prospective physician's journey.
And that control is just about absolute, isn't it?
Yeah.
When we talk about influence, we're not talking about suggested guidelines. This is a vertical monopoly on entry. What are the key mandatory services that give the AAMC this immense structural power?
Well, the AAMC's power, it stems directly from controlling 3 mandatory services that pretty much every single aspiring American doctor has to use. First, you have the MCAT, the Medical College Admission Test. Second, the Centralized Application Service, AMCS, which processes nearly all applications to U.S. medical schools. And third, they control the residency process through ERS, the Electronic Residency Application Service. If you want to become a doctor in America, you have to go through them.
That sounds like an incredibly powerful financial engine. What are we talking about in terms of the scale of revenue that this bottleneck generates?
It's staggering. In 2022 alone, these mandatory fee-based services generated over $200 million in revenue. This capital gives them not only immense lobbying power, but also the funds to push their specific ideological agenda throughout the entire medical education pipeline. It ensures adherence from admissions right through to residency.
So the first, and you could argue the most critical, battleground here is admissions. We're seeing this shift away from objective academic metrics like test scores toward more subjective criteria, often framed around ideological alignment. The AAMC openly promotes a shift to holistic review. What does holistic review actually mean in practice today?
Historically, holistic review meant looking at a candidate beyond just their grades, considering life experience, volunteering, research, that sort of thing. But today, the AAMC is guiding admissions committees to prioritize experiences and attributes over traditional academic metrics, specifically MCAT scores and GPAs. And that allows them to devalue what were once considered the core measures of academic merit.
But wait a minute, the MCAT is supposed to be the foundational measure of preparation. What did the AAMC's own validity committees find about the test itself? Doesn't their own data confirm it works?
This is where the critique of the AAMC strategy becomes really sharp. Psychometric analysis performed on the MCAT exam found no intrinsic bias within any demographic group. The analysis confirmed that the MCAT is a strong measure of the level of achievement necessary for a student to succeed in medical school. In fact, one committee chair even noted its psychometric properties demonstrated intrinsic equity in its measurement. The test works.
So the test works, but the AAMC is still pushing to discount the results.
They are. They instruct admissions officers to view differences in scores for underrepresented groups not as a reflection of, say, differential academic preparation, but as reflections of societal inequalities. The argument becomes the test must be biased because the context, socioeconomic background, education, opportunity is not equally distributed. Therefore, the scores have to be viewed as secondary to lived experience and attributes.
And they've literally incorporated this worldview directly into the test content itself.
Yes, that's a key point. Identity politics are now structurally baked into the MPEG's content outline. You mentioned the psychometrics, but look at the material they're actually testing. Specifically, Foundational Concept 10 focuses entirely on social inequality. The content explicitly addresses institutionalized racism and discrimination as drivers of health outcomes. And crucially, the concept outline states that an understanding of these barriers, informed by perspectives such as social justice, is essential to address health disparities.
So future doctors aren't just being tested on organic chemistry. They're being tested on their political perspective and their understanding of social justice terminology.
In a very real sense, yes. That ideological focus then flows straight into the application itself. After the big Supreme Court decisions on affirmative action, the AMCAS application service became the central tool for collecting this race-adjacent ideological data. It's the ultimate loophole strategy.
A deliberate attempt to sidestep the ruling.
It's certainly viewed that way by critics. For the 2024 AMCAS, they added social justice advocacy as a formal work activity experience type that applicants are encouraged to highlight. The AMC even provided explicit examples of what counts.
What kind of things?
Advocating for civil rights, registering people to vote, and even climate activism. The AAMC stated very explicitly that this edition was intended to help signal to applicants the importance of participating in social justice and advocacy work.
So volunteering in a hospital pharmacy could be measured on the same scale as registering voters for a political campaign, all under the umbrella of experiences.
Yeah.
And then there's the use of lived experience.
That's the softer workaround. The application asks about other impactful experiences, encouraging applicants to discuss challenges they've overcome: family background, financial circumstances, education. To critics, this focus on lived experience is a clear invitation to discuss the impact of race and is a known strategy to circumvent bans on considering race directly. They're essentially coaching applicants on how to frame their background in a way that aligns with the ideological goals of the admissions committees.
And if all that weren't enough, the AAMC introduced a brand new standardized test to screen for these subjective attributes: the Professional Readiness Exam, or Preview, which starts in April 2025.
The Preview exam adds a completely new layer of screening for ideological alignment. It's scored from 1 to 9. And while it does include necessary competencies like teamwork, 2 of the 9 defined competencies are cultural awareness and cultural humility. Those are terms that have become absolutely central to the anti-racism and implicit bias curriculum.
Can you give me an example of the kind of ideological screening this test involves? What are the scenarios asking applicants to demonstrate?
Oh, the sample questions are incredibly revealing. They move way beyond simple professional ethics. One involves a scenario where a teaching assistant teases a classmate about their ethnic background, a classic microaggressions scenario, and the applicant has to choose the appropriate response. That response is often framed as prioritizing the victim's emotional experience over just stopping the behavior. Another one asks the applicant to respond after realizing every single patient actor they interviewed during a course was white, and their instructor just dismisses the lack of diversity.
So the test essentially forces applicants to validate and adhere to the language and framework of DEI ideology to score highly.
Exactly. The preview exam ensures that applicants are screened for their ideological perspective before they ever even meet an admissions officer.
Okay, so the ideological screening starts the application and testing phase. But the AAMC's structural power doesn't stop there. It follows the student through medical school and into residency, ensuring conformity through accreditation and the residency placement process. How does the AAMC ensure this adherence inside the medical school environment itself?
They do it through their influence on the Liaison Committee on Medical Education, the LCME. This is the body that dictates accreditation standards for all allopathic medical schools, and it's jointly sponsored by the AAMC and the American Medical Association, the AMA. If a school doesn't meet LCME standards, it risks losing its accreditation, which is basically the death penalty for a medical school.
What are some of the specific diversity mandates within those LCME standards?
Well, you can look at element 3.3, which is about the academic and learning environment. It requires programs to ensure the environment recognizes the benefits of diversity and reflects focused recruitment and retention activities. This pressure is highly prescriptive. We saw the real-world effect of this when the University of Utah School of Medicine was specifically criticized in its 2021 post-survey report. Why? For not making enough faculty and senior staff offers in several of the school's diversity categories. They were essentially told by the accreditors to compensate for their lack of specific diversity outcomes, which led to the creation of race and ethnicity-based scholarships to meet that external pressure.
That sounds like accreditation is functionally enforcing quotas, even if they deny it when they're pressed on.
Precisely. And when legislative bodies, like the House Committee on Education and the Workforce, raised concerns about these diversity quotas, the LCME issued a clarification. They stated that nothing in their standards mandates the specific categories of diversity a school must use, nor does it require race-based scholarships. However, the regulatory actions they took against schools like Utah demonstrate that the accreditors interpret element 3.3 as a mandate for achieving specific numerical diversity outcomes. It's a classic bureaucratic pressure tactic.
And beyond just demographics, the accreditation process also mandates curriculum content, right? It embeds the AAMC's specific view of social justice right into the teaching.
Standard 6 is crucial here. It mandates that medical schools teach students to recognize and appropriately address biases in themselves, in others, and in the healthcare delivery system. This solidifies the AAMC's stance that anti-bias training, specifically focused on implicit bias and anti-racism, is a core part of the contemporary practice of medicine. This is required training, even though critics point out that a lot of research has challenged the reliability and the effectiveness of many implicit bias claims.
So after 4 years of medical school shaped by these AAMC accreditation rules, the student then has to apply for residency through the AAMC-controlled process, which just continues the ideological screening.
The mandate follows them all the way through the Electronic Residency Application Service, ERS, and the Medical Student Performance Evaluation, or Dean's Letter, the MSPE. Both of those collect identity data. We saw concrete examples of this in 2023 when the Diversity and Emergency Medicine Questionnaire actively used ERS data to push residency directors toward racially conscious residency placement. The stated goal is to ensure DEI is integrated in a fair and equitable way, which means in a way that prioritizes racial and identity consciousness in placement decisions.
And now we're seeing new pathways being designed specifically to reward ideological alignment during the residency application process itself.
Yes, exactly. Consider programs like the one at Southern Illinois University, their Health Equity Scholar Pathway. Students who complete required lectures and workshops on anti-oppressive medical practices receive a special distinction, the Health Equity Scholar, which is noted on their residency applications and their dean's letters. The message is completely unambiguous. Your willingness to adopt and complete training based on a specific divisive ideology is now a distinguishing positive factor in your residency acceptance. It could potentially outweigh pure clinical aptitude.
This systematic, end-to-end control led the Coalition for Physician Accountability. which of course includes the AAMC, to publish some highly specific recommendations back in 2021 about graduate medical education.
That was the UME-GME Review Committee report, a very long document that really provided a blueprint for institutionalizing these concepts. One of its key themes was diversity, equity, and inclusion. It explicitly recommended that residency organizations mandate training in anti-racism, avoiding bias, and ensuring equity.
What was perhaps the most, let's say, controversial recommendation regarding academic performance?
The recommendation about grade assessment was certainly the most provocative. The UGRC report went so far as to recommend that medical schools evaluate patterns of grade distribution based on characteristics like race, ethnicity, and gender identity. Why? To eliminate systemic biases in grading.
Wait, hold on. They suggested assessing student grades based on race to ensure equity. That seems to undermine the very idea of a meritocratic objective evaluation.
Recommendation 10 asserts that, and I'm quoting here, inherent biases exist in clinical grading and assessment. Therefore, the school must use demographic data on race, ethnicity, and gender identity to review grade distribution patterns for continuous quality improvement. Then, Recommendation 16 advises programs to make adjustments that promote equity based on self-reported demographic information. The core mandate is clear. The responsibility of the medical school is to promote equity and diversity across the board, using applicant demographics to address perceived bias before objective assessment and evaluation can even take place.
This pervasive influence across the entire pipeline, from the MCAT to residency placement, it's clearly a centralized project. This isn't some grassroots student movement. It's a top-down transformation backed by strategic leadership statements and, well, massive financial resources, all fueling policy advocacy that explicitly pushes divisive concepts into the medical sphere.
And when you look at the leadership, the commitment to this mission is unmistakable. The CEO, David J. Skorton, whose compensation was over $1.6 million in 2022, and the chief DEI officer, David A. Acosta, who earned over $618,000 in 2022. They openly champion anti-racism and social justice as central to the AAMC's mission.
And they don't shy away from linking national political and social events to their mandate for physician activism.
They absolutely see medicine as a political tool. They explicitly invoke the names of George Floyd and Breonna Taylor in 2020 to call on academic medicine to unite and employ anti-racist and unconscious bias training. They also connected mass shootings to structural racism to push physicians toward activism on things like gun control and immigration, referencing external political resources like the Southern Poverty Law Center. Critics argue this represents a deliberate medicalization of social issues, positioning political activism as inseparable from contemporary clinical practice.
Let's talk about some of their specific and highly controversial policy positions that appear to prioritize ideology over prevailing evidence. The concept of racial concordance is one they champion, despite some pretty conflicting data.
Right. Racial concordance is the idea that a patient and a provider who share the same race will have better clinical outcomes. The theory is that it improves communication, trust, and adherence to medical advice. The AAMC consistently supports this idea. The critical counterpoint, however, is that 4 out of 5 available systematic reviews, including one from 2023, show no evidence to support this claim.
So the majority of rigorous scientific reviews contradict the AAMC's policy position, yet they continue to assert it. Why would they do that?
Well, politically, the idea is incredibly powerful because it supports the need for targeted diversity initiatives in medical schools. Critics argue the AAMC engages in cherry-picking weak evidence to reinforce a specific point of view, that diversity must be achieved to ensure better health outcomes for specific racial groups. It positions the push for demographic change as a clinical necessity, which can override concerns about meritocracy or academic standards.
Another area where they've taken a very firm policy stance is regarding youth gender ideology.
The AAMC is a very strong advocate for gender-affirming care for minors. CEO Skorton stated back in 2021 that restrictions on this type of care would promote discrimination and widen already significant health inequities. They've joined numerous AMCAS briefs with major organizations like the AMA and the AAP, opposing state bans and stating that such treatment, including hormones and puberty blockers, is medically necessary and evidence-based. And they've done this even as international medical bodies have begun reversing their stances or restricting access due to poor long-term evidence.
So we have an organization that controls the entire pipeline, dictates the curriculum, and takes these firm policy stances on highly debated political and social issues. But maybe the most concerning part is how they attempt to control the very language used by doctors and researchers.
This is what some call the Orwellian language control aspect, and it aims to embed identity politics deep into medical discourse. The AAMC collaborated on a guide to language that explicitly attempts to recast medical issues through a specific political lens. The guide makes these foundational declarative statements like, and I'm quoting, "Narratives grounded in white supremacy and sustaining structural racism perpetuate cumulative disadvantage for some populations and cumulative advantage for white people, and especially white men."
That's incredibly explicit. How does that translate into changing a simple descriptive medical statement?
The revisions are designed to force practitioners to attribute health outcomes not to biology or diet or individual behavior, but to political systems. The classic example that critics cite is transforming the statement. Low-income people have the highest level of coronary artery disease. The AAMC promoted revision is this long phrase that attributes the disease to banking policies, real estate developers, gentrifying neighborhoods, and corporations weakening the power of labor movements, among others.
Wow. That's a stunning level of complexity for a simple medical description. Why mandate that doctors use such convoluted, politically charged phrasing?
It's strategic. By attributing coronary artery disease to banking policies, they shift the blame away from the patient or biological factors and onto structural racism. It turns every single health disparity into a mandate for social justice activism, which then justifies the AAMC's push for physicians to become political advocates rather than focusing solely on clinical treatment and research.
And all of this ideological maneuvering, the policy lobbying, the curriculum mandates, it all requires substantial funding. We already discussed the $200 million they generate internally from mandatory fees. What's the scale of the external funding supporting this mission shift?
Well, that internal revenue is supplemented by massive external funding streams, both public and private. Since 2003, the AAMC has received more than $33.9 million in private foundation grants.
And which organization is the largest driver of that ideological funding?
The largest single donor is the Robert Wood Johnson Foundation, or RWJF. They gave over $24 million for a program explicitly titled Confronting Structural Racism to Transform Health. This funding isn't for medical technology or disease research. It's explicitly aimed at transforming inequitable institutions, systems, and social practices within academic medicine. On top of that, the AAMC has received over $9 million in federal grants since 2020, which means U.S. taxpayer dollars are directly contributing to an organization that is actively involved in pushing these political and ideological agendas.
And they also use their funds to support ideologically aligned satellite organizations, making sure the message is spread throughout the system.
Exactly. They granted over $711,000 to the National Medical Fellowships, which provides scholarships only to students chronically underrepresented in medicine, adhering to the AAMC's specific demographic definitions. More specifically, their internal grant programs, like the NextT Grant Nurturing Experiences for Tomorrow's Community Leaders, are crucial for embedding this controversial content.
Can you give us a concrete example of what those NEXT grants fund and how it influences training?
Sure. The University of North Carolina at Chapel Hill, for instance, is using AAMC funds to develop an anti-racist resident curriculum through community-partnered story sharing. The explicit goal is to integrate patient-informed racial justice content into resident training. Similarly, Western Michigan University used its funds for a project that engages residents in anti-racist service learning and systems change activities. The resources recommended for this training include guides on white racial identity development and controversial books like Me and White Supremacy. This shows that the financial power is directly used to embed anti-racist pedagogy deep into medical curriculum, often relying on concepts that many critics find divisive.
So it's clear they dictate the curriculum and policy, but they also weaponize the vast amount of data they collect through their monopoly services. That has to be the ultimate tool for centralized ideological enforcement.
Their data warehouse gives them unparalleled control. When the AAMC publishes its physician supply and demand reports, they don't just use simple demographics. They use what they call healthcare utilization equity scenarios that factor in patient race and ethnicity. These projections explicitly calculate the additional physician demand needed to achieve healthcare utilization equity, which indicates a targeted approach to increasing physician supply based on the perceived needs of various identity groups.
So instead of projecting, say, the number of dermatologists needed based on population trends, they're projecting the number of physicians needed based on achieving a specific racial utilization target.
That is the mechanism. They're using their data monopoly to project the workforce based on equity goals rather than purely on demographic needs or clinical specialization. This effectively directs where future doctors should come from and who they should treat. And they reinforce this internally through faculty surveys like the Standpoint Faculty Engagement Survey, which measures faculty perceptions of DEI efforts. When the results showed that over 100 faculty members felt no additional DEI efforts were needed, believing it came at the expense of other values, the AAMC leadership's response was very instructive. They didn't pause or adjust. They said leaders must continue to educate those dissenting faculty about how DEI upholds institutional excellence. The narrative is simply non-negotiable.
That was a powerful, really detailed look at the internal ideological forces shaping the pipeline. We went from the MCAT all the way to RWJF grants. Now we have to pivot to the practical outcomes in the treatment room. If the U.S. system is being pushed toward this bureaucratic, ideologically driven model, what can we learn from systems that are already centralized, like the UK's National Health Service, the NHS? We have a qualitative analysis comparing the U.S. and UK systems, offering direct patient insights that capture the human trade-offs involved.
We have to start with the baseline metrics. Quantitatively, the systems look very different. In 2019, the U.S. spent a staggering 16.8% of GDP on health. The UK spent only 10.2%. Yet the UK had a higher life expectancy, 80.9 years versus 77.3, and a lower infant mortality rate. But despite these better aggregate health outcomes, the U.S. system is often praised for its technology and speed. When we dive into the patient experience, the core conflict emerges. It's accessibility versus availability.
Okay, let's start with the UK model. Universal healthcare, where the financial barriers are essentially removed. What's the lived experience of that system?
The UK system is built on the premise that healthcare is a basic human right, funded entirely by general taxation. The primary positive attribute noted by the interviewees is the immense financial relief. The stress of cost is eliminated. People know they'll always receive care, regardless of their ailment or their background. This fosters a sense of security and provides a universal baseline of care.
But the famous drawback, the one that ties right back to that New York strike scenario, is the strain on resources and the resulting delays.
That is the major unavoidable negative attribute, the long wait times. Because the service is free at the point of use, increased accessibility leads to what some call overuse and drastically escalating delays. Patients mentioned that the wait time for specialist appointments, routine surgeries, or even essential diagnostic testing was exponentially greater than what they experienced in the U.S. This led some individuals to deter seeking care entirely, even when they needed it, simply because the wait was too daunting.
That's the resource strain in action. How does the funding model specifically restrict quality or speed of care?
Because the funding relies entirely on a fixed annual tax budget, providers become far more reluctant to order additional testing, like expensive CT scans or MRIs. The supply is finite. Patients often experience less privacy, with multiple beds, multiple patients per hospital room, reflecting the lack of facility capacity. This constraint perfectly mirrors that bureaucratic decay we feared. High accessibility combined with capped resources means efficiency and speed just collapse.
Okay, now let's contrast that with the American system, which uses financial costs as the primary regulator of access.
The U.S. model, driven by private healthcare and insurance, is characterized by quick care, specialized services, and time-sensitive treatment if you can pay for it. The positive attribute is quick access to emergency, urgent, and primary care options. And critically, providers are far more willing to order additional tests and scans, MRIs, CTs, you name it, during initial visits because insurance or private payment covers the cost. This willingness to provide preventative and diagnostic services up front exists because the financial incentive structure supports it rather than punishes it.
So if you have coverage, the U.S. system prioritizes availability and speed. But what's the devastating flip side of that cost-driven efficiency?
The negative attribute is the overwhelming financial burden. The sheer cost causes limited accessibility for the general public and a profound reluctance to seek care due to the fear of crippling medical debt. Interviewees noted that the U.S. system benefits those who have the financial means and privilege. Quick, attentive care is accessible primarily to those who can afford the insurance or the out-of-pocket expenses. As one participant put it very succinctly, if you're not in a financial bracket that can cover the extreme costs, the availability is completely trumped by the financial toll.
So we have two systems trading opposite goods. In the UK, care is affordable and universally accessible, but availability is restricted by time and resources, leading to delays. In the US, availability and speed are high, but accessibility is severely restricted by affordability, creating a privilege problem.
And despite their structural differences, both systems are facing a universal challenge, a critical staffing shortage. However, the reasons for this shortage fundamentally differ based on their respective funding models.
How does the UK funding model drive its staffing shortage?
In the UK, the shortage is often attributed directly to inadequate compensation for very high hours. Because the NHS is tax-funded, salaries and resources are capped, making it difficult to recruit and retain specialized staff in a competitive global market. The commitment is to universal care, but the cost control means the personnel are often underpaid relative to the demands of the job.
And in the US, where salaries are generally higher for healthcare workers.
In the US, the shortage correlates more closely with issues of education, training, and recruitment, the very pipeline issues the AAMC is trying to control. High burnout rates are endemic, but the fundamental struggle is with the supply of qualified physicians and nurses entering the system. And that's an issue compounded by high debt loads and now potentially the ideological burden of medical education.
So let's look at the quality of care perception. How do patients gauge quality in these two radically different environments?
Quality perception is a very subjective trade-off. In the US, the standard of care is explicitly dictated by whatever your budget or insurance allows. The provider is generally attentive and focused on the individual because the volume is regulated by cost. You get a higher level of attention and technology for your money.
And in the UK?
In the UK, the care is described as highly sympathetic, which reflects the ideology of healthcare as a right. However, practitioners may not be able to deliver the highest quality due to understaffing or lacking facility capacity. The care is high-touch in spirit, but often rushed or constrained in its execution.
So the ultimate tension is clear. The aspirational goal of absolute accessibility, which leads to the resource strain and delays we see in the NHS and in that fictional New York scenario, versus the fundamental necessity of simply providing competent, timely, and available care, which the U.S. system provides efficiently, but only to a restricted group. This makes the ideological capture of the American pipeline even more dangerous, as it risks imposing the bureaucratic inefficiencies of the UK model onto a system that's already struggling with its own cost crisis.
This deep dive has really established a massive, well-funded force, the AAMC, pushing an ideological agenda that risks undermining competency in American medicine. And at the same time, the practical outcomes in centralized systems like the UK's reveal systemic flaws where resources are the ultimate regulator. This aggressive ideological capture has, predictably, generated significant political and legislative friction aimed at protecting merit.
And the first friction points are appearing at the state level, attempting to curb DEI mandates in publicly funded institutions, including medical schools.
That's right. 8 states have taken legislative action to eliminate DEI-influenced programs and mandatory training in public institutions. Utah and Oklahoma have banned DEI offices and the mandated use of state assets for such programs. This state action was necessary because medical students and faculty initially put up alarmist messaging, claiming that prohibiting DEI would inevitably put the institution's accreditation at risk because of the LCME standards.
That sounds like a powerful intimidation tactic, but was that claim even true, that removing DEI offices would jeopardize accreditation?
No, it was essentially misinformation. The LCME subsequently clarified that nothing in its standards mandates the specific categories of diversity a school must use or requires race-based scholarships. The plain text of the accreditation standards does not compel the existence of DEI offices. This clarification was crucial for state lawmakers, as it debunks the idea that they cannot legislate against these specific practices without destroying their medical schools.
Okay, so moving to the federal level, Congressman Greg Murphy, who is a physician, introduced the EDUCAT Act. What's the core mechanism of this proposed federal legislation?
The EDUCAT Act, that's the Embracing Anti-Discrimination, Unbiased Curricula, and Advancing Truth in Education Act, aims to ban discriminatory mandates across medical schools and their accrediting entities. Its core mechanism is financial. It calls for withholding federal funds from medical education programs that maintain DEI departments or compel faculty and students to espouse DEI concepts. The idea is to sever the financial pipeline that supports policies perceived to be in opposition to federal non-discrimination principles, addressing the fact that federal dollars help fund these ideologically specific practices.
This is a direct attack on the financial lifeblood of the AAMC and its member institutions. How has the AAMC, with its hundreds of millions in revenue, responded to this direct legislative threat?
They've mobilized their entire network. The AAMC actively opposes the Educate Act and immediately sent urgent communications to their member institutions and affinity groups, urging them to advocate against the bill. They published materials countering what they called common myths about DEI.
And what were some of the specific myths they were trying to debunk?
Well, they claim their efforts are not political in nature and that they do not allow unqualified students to enter medical school. Critics argue these claims are laughable, given that the AAMC is simultaneously promoting specific political concepts like anti-racism and mandating training that defines race as a social construct. Their narrative is designed to decouple their political advocacy from their academic function, a separation critics argue is impossible given their policy positions.
And at the same time, they're pushing proactive legislation in the opposite direction, essentially creating a legislative counteroffensive.
Precisely. They promoted counter-resolutions in Congress, like House Resolution 1180, which recognizes the importance of DEI efforts in medical education. This resolution uses language that defends their push for diversity, citing that same unsupported notion of racial concordance and declaring that bias and racism in medical education directly impacts the delivery of equitable healthcare. Furthermore, the AAMC is actively turning physicians into political activists using their curriculum platforms.
How are they achieving that level of political mobilization and training?
The AAMC uses programs like its Ideas Learning series to push political activism. They unveiled an advocacy toolkit for physicians in training and promote voters' education initiatives. They explicitly argue that voting is a social determinant of health and are partnering with organizations that push voter registration during routine patient visits. This connects right back to the language control we discussed earlier, where every health issue is framed as a political issue that requires activism. So when a single private organization controls testing, applications, accreditation, and policy generating hundreds of millions in revenue and engaging in explicit political activism, the need for accountability and oversight becomes critical to restoring a focus on merit and competence.
What's the biggest structural problem that makes the AAMC so opaque and difficult to challenge?
The lack of transparency is primary. As a private nonprofit, the AAMC isn't subject to public records requests, which shields it from scrutiny. Most critically, the AAMC has not posted an annual report detailing its governance, activities, financial highlights, or its political advocacy since the year 2000. This absence of public financial and operational disclosure for over 2 decades, coupled with their increasing political advocacy, presents a massive accountability issue for an organization that controls the entire medical pipeline.
And when you look at their total control over the entry points, MCAT, MCAS, LCME, it sounds less like a nonprofit association and more like a textbook monopoly.
That is the argument critics are increasingly making. The AAMC's overwhelming dominance might make it vulnerable to litigation under federal antitrust statutes. Their monopoly over the mandatory application services and their influence over accreditation through the LCME mirror past antitrust issues seen in other higher education application services. Accountability has to be enhanced, particularly in how they manage the tens of millions generated by these mandatory services and how those funds are then used to promote a specific political agenda.
The central argument here remains that the AAMC has fundamentally replaced its original mission of promoting excellence in medical education with an ideological prescription.
Absolutely. They are committed to transforming health, but their actions demonstrate a prioritization of activism and identity politics over the traditional pursuit of clinical excellence and established biological science. The lifeblood of this politicization flows directly through the AAMC's structural power and its financial ability to embed DEI across the entire medical education continuum, potentially compromising the quality and competence of the next generation of physicians.
What we've detailed here is a powerful self-sustaining feedback loop. A major organization uses its financial and structural monopoly to impose an activist ideology throughout medical education, promoting concepts like racial concordance and devaluing traditional markers of merit. Meanwhile, patient experience, both in our cost-prohibitive system and the resource-strained universal model,
suggests that the focus is dangerously moving away from basic, timely clinical care. We are seeing the American medical system, long celebrated as a global engine of healing, simultaneously battling against ideological capture at its highest levels and facing the practical breakdown of function. The same resource constraints and ideological weaponization that characterized the European disease we once viewed as a distant warning. The tension lies between the aspirational goal of health equity and the fundamental necessity of simply providing competent care when a child is gasping for air outside the hospital doors.
The future of healthcare depends entirely on whether merit and biological reality can reclaim priority over the weaponization of essential services in the name of political orthodoxy. This conflict isn't just about politics. It's about competence, resource management, and who ultimately gets care and when.